Hey everyone, it's Dr. Hodges. It is a beautiful, crisp day, and I thought, why not go for a walk, take the Pipster out, and let's talk a little science. So, I think the first thing that I really wanted to talk about was I got in the mail today general surgery news, and it's just a newsletter, like a newspaper. Literally, my daughter, we went to a coffee shop the other day, and she said they still make newspapers as I was reading the Wall Street Journal at LDU. So yes, they still make newspapers, and we get I get a general surgery one in the mail. And I think it was interesting. The topic that they were talking about was the fusion of GLP-1s and their effect on surgery, and not just bariatric surgery, but surgery as a whole. And I think when the authors were speaking, I really appreciated that they were speaking to a much larger issue that is going on in medicine. If anybody has followed my channel for a while, I think number one, you will know that I'm a firm believer, and I know obesity is a disease. And if we are going to treat it adequately and to give our patients the best chance at a long, happy, healthy life, get them in a good, safe weight and BMI, help them have resolution of their health problems, we have to treat this like a disease. And right now, the general public is poorly informed, and frankly, other providers in our profession are not well informed either. I mean, I still get family practice doctors that will refer patients to me for a lap band. I mean, I don't even know the last time somebody got a lap band, but it's because they're just not well informed. And we as bariatric surgeons and in the field of bariatric medicine and obesity medicine, it is our job. We need to do a much better job at educating our colleagues and informing the public on what the latest information is, what the best treatments are. And I thought it was interesting, one of the recommendations that was given was that we should be treating obesity not just as a chronic disease, but looking at this chronic disease as a continuity of care. So for instance, and they compared it to having specific protocols like what you would see in cancer treatment. And so, for instance, if a patient presents to you with a cancer, they are staged, and then sometimes they're given neoadjuvant therapy, meaning a medication before a surgery. They're determined what is the best option. Is it surgical? Is it medical? Are they maybe only a candidate for medicine? And so trying to approach surgery and medicine and combining the two, that is where some are saying is the best. And I have to agree. I wholeheartedly believe that medication and diet and having a good comprehensive approach is going to be the best chance that patients have at long-term success. However, medicine is woefully inadequate if you have more than 40 to 50 pounds to lose. So even if you go to a website for GLP-1s, if you go to the website for Victoza, if you go to the website for Mounjaro, and these are the medications that are made for diabetes, or if you go to the website for Zepbound, you go to the website for Wegovy, they will say you will lose 20% of your weight. Okay, what that means is for every 100 pounds that you're overweight, you will lose 20 pounds. So, I am 4'11". My ideal weight is actually 95 pounds, but let's say it's 100 pounds. If I weigh 200 pounds, what that is saying is, by these companies' standards, with their published results, with their medication, I will lose 20 pounds. Now, if I am 4'11" and I weigh 200 pounds, I am certainly going to be obese and I need to lose more than just 20 pounds so I can have longevity in my life. You know, if you have a BMI over 35, you have the same life expectancy as somebody that's been smoking a pack a day for 20 years. And so that is where we have to start having real conversations with our patients as to what is best. Is it medicine? Is it medicine and surgery? Is it surgery and then medicine afterwards? We have not had really good deep dives into combinations of these. I will tell you that there was a large study that was performed and it was presented this past summer. It was June 2025. It was presented at ASMBS, and they looked at 53,000 patients. That is a large number of patients. And they compared GLP-1s, which are the injections that you see all advertised, and they compared weight loss from GLP-1s to sleeve and gastric bypass. And surgery blew it out of the water. I mean, you lost 5 times the amount. And I'm going to do another video looking specifically at this study. And so we all know that surgery is going to be the best and the most definitive way to get the weight off and to keep the weight off. But what role do GLP-1s and injections, or what if you're not a candidate for those, or you can't afford those? What is the role for other medications that are oral? That's not an oral GLP-1. Like whenever I'm talking about an oral medicine, I mean a combination of like phentermine and Tepemax, or Contrave, which is a combination of Wellbutrin and naltrexone. How well do those work as a potential either neoadjuvant, meaning before you have a surgery, or afterwards as just an adjuvant, meaning an additional, I want to say procedure, but as an additional treatment. So I think that this is some good food for thought. It is going to take more research, and it is going to take more buy-in from the medical community to take away this bias. I have a patient right now that, hi there. Hello, baby. I have a patient right now who needs to have surgery on their back, and they were referred by their orthopedic surgeon. They have fantastic insurance. In fact, they really don't pay much. Their insurance is Lantern. So, little FYI, shout out to Lantern. If your company offers a Lantern rider on your insurance plan, OMG, sign up, because it's fantastic. It's very little out of pocket for a patient if they're going to have any kind of surgery. And this patient needs to lose at least another 60 to 80 pounds before they're a candidate for their orthopedic surgery. Now, they have been on, when they came to see me, they just did not feel very comfortable having a surgery. They just mentally were not there. You know, I worked with that patient for a year. They have lost about 45 pounds, and then they'll go off the medicine and they have some weight regain, and then they try to go back on, and then they lose a little bit more. And so they still need to lose 80 more pounds, and we're getting up to the highest dose of the GLP-1s, and they're getting a little nervous. And I've broached the subject of surgery again, and they're a little nervous and they're just not there. And I never want to pressure anybody into doing something that they don't want to do. However, I have to say, at some point, how much of a disservice am I doing my patients if I'm not a little bit more forceful? Like, I want to give them the very best treatment possible. I want them to lose weight. I mean, they really probably need to lose a good 100 pounds. I'm just talking about the amount of weight that their ortho wants them to lose just so they can be a candidate for surgery. But really, they need to lose about 100 pounds. The medicine is just not going to be there, and it's not for lack of trying, and it's because they're just not receiving adequate care. Okay, and when I say adequate care, I mean, they're basically being underdosed. So for instance, let's say you have high blood pressure and you're taking 2 blood pressure pills, let's just say, and the top number is still 180, 190. Well, guess what? You probably need another medicine, or you need to max out those medicines. But you have to keep on, you need more treatment. That's kind of where I am with this one little patient. But it's difficult because in the field of weight loss, there are so many different biases, and there's so much noise that is out there. And the reality is that it's safer to have surgery than to have your gallbladder out. The issues of safety, of complications after surgery, the issues of mortality, those have all vastly changed over the last 20, 25 years. These are very safe surgeries now. And so I just find it so unfortunate whenever patients are still very concerned about a surgery because maybe their primary care doctor, they don't know any better, and they're not encouraging them to have a procedure, even though the procedure is the best thing for them. Or maybe their best friend's cousin or their brother's wife's hairdresser said, you know, my boyfriend had surgery and they did terrible. And that's what they kind of latch on to. And so it just makes what I have to do and what I can offer my patients it makes it that much more difficult. But it just takes time, because if you're not ready and you have a surgery, you may not have as good of an outcome because you may not be doing everything that you need to do. But the reality is that if you go on a medicine and you do not do all the things that you need to do, guess what? You're not going to have a good outcome with those either. You're not going to lose any weight, and you're certainly not going to have any longevity of that weight loss. So I really think my job is not just to give good surgeries and offer good patient care, but I want to be the sounding board this year of really getting education out. We need to do a much better job of educating our colleagues. I'm here in Dallas. One of my goals this year is to talk with more nursing programs, to talk with some of the allied health professionals and nurse practitioners and the PA programs, and even see if I can talk at the medical schools about obesity, because we need to have a fundamental change in our approach to obesity medicine. And that's my 2 cents.